Where do we see the future of blinatumomab or other B-cell directed, CD19 directed, let's say, therapies and affecting the dose and duration of asparaginase? You provided a very provocative study, Jay. I will start with Steve and then carry on.
Because of the remarkably good results with blinatumomab, almost every cooperative group in the world is looking at ways to remove elements of chemotherapy in patients with B lineage ALL who respond well. And I think asparaginase is part of those changes.
I think we're moving towards trying to use more of these immunotherapies and less chemotherapy, and I know that's a conversation we're having in the younger adult space for the cooperative groups. And while we had challenges with our inotuzumab A041501 trial, we're hoping that maybe by further reducing either the inotuzumab or then I think probably the next steps after that study will be to give some inotuzumab, maybe even as an induction, and then reduce the chemotherapy. And so I think it's trying to incorporate more of the immunotherapies and less of the chemo.
The Ph positive was a good example for me to learn that they dramatically changed how we think about an ALL. We have learned a lot from the pediatrics from applying those. And older ALL is the first place that we went minimizing the chemotherapy, the blinatumomab, partly because we did a very effective TKI, and then now we're using very little chemo altogether for that age group and still cure the group, which is incredible. So I think it's a similar trend hopefully we'll see in Ph negative ALL and in younger patients as well too. It will be done in sequence. The whole therapy I'm hoping to be a lot shorter with incorporation therapy with less chemotherapy too. Maybe with a blinatumomab, maybe even with a CAR T cells as a consolidation in some cases. Obviously all needs to be prospectively.